Dear PWNs, the topic for today is urinary tract infection in children. It is such a common entity and there has been so many changes that has been happening in the world right now with regard to investigation or with regard to drugs. So what is the simple approach to urinary tract infection in children? So our topic for today is urinary tract infection in children. That is the topic for today. Okay, remember, urinary tract infection in children can occur in both boys and girls. Remember, less than 2 years, it is equal proportion. Both boys and girls have got. So less than 2 years. So less than 2 years, it can occur in both boys and girls equally. So less than 2 years, less than 1 year in infants. In infants, boys and girls have equal proportion. So boys are as equally affected as girls. So 1:1 ratio, because urinary tract anomalies are common in boys. Urinary tract anomalies are common in boys. But after common in boys. But when you after beyond infancy, so after infancy, it is girls have got more infection compared to boys because of short urethra. Girls have got more infection compared to boys, right? So with respect to urinary tract infection, what are all the things that you need to know apart from this? Very simple. The first thing is, based on the organism, you can say E. coli UTI and non-E. coli UTI. So based on the organism, one is E. coli UTI and the second one is non-E. coli UTI. Non-E. coli UTI. Okay, E. coli UTI is common. You need not screen any children. Need not screen for any anatomical abnormalities. You need not screen. But as far as a non-E. coli infection, whenever you get Proteus, whenever you get Pseudomonas, okay, or any other organism, you need to investigate the child for urinary tract abnormalities. Okay, you need to screen the children. That's why if culture shows E. coli, don't worry. If the culture doesn't show E. coli and some other organism like a Proteus, Pseudomonas, and as such Klebsiella also, there is underlying anatomical abnormalities unless otherwise proved. Then you need to know upper UTI and lower UTI. What is that called as? Upper and lower UTI. So what is called upper UTI? Upper UTI is involvement of nephrons, otherwise known as pyelonephritis. It is called pyelonephritis. This is called upper UTI. It involves the lobes of kidney. That is upper UTI. The child will be toxic and the child will have high grade fever and the child will have renal angle tenderness and the child will have vomiting. Sometimes it can be associated with raised creatinine. So upper UTI is called pyelonephritis, whereas lower UTI, what is called lower UTI? Lower UTI is involvement of urinary bladder alone, otherwise called as cystitis. Remember, in cystitis, the high fever is low grade. It is usually not high grade. It is low grade fever. And it is associated with dysuria. It is associated with the increased frequency, and it is associated with the, so one is dysuria, second one is increased frequency, and then third one is difficulty in micturition. Both are one and the same. This is cystitis. Okay, so now we have seen what about boys and girls, what about E. coli UTI, what about non-E. coli UTI. what is upper urinary tract infection, what is lower urinary tract infection. So this is the thing that we had seen so far. Then what do you mean by complicated UTI? What is that complicated UTI? Okay, so what do you mean by complicated UTI? Right. So complicated UTI means if it is associated, as I told you, high grade fever. Okay, one second. So what do you mean by complicated UTI? Complicated UTI is classified as I told you already, complicated UTI means it is associated with renal angle tenderness. It is associated with renal angle tenderness. It is associated with toxemia. It is associated with sepsis. It is associated with elevated creatinine, and it is associated with high grade fever. This is called as complicated UTI. Then what is called as simple UTI? Second one is what is called simple UTI. Simple UTI is nothing but your cystitis is simple UTI, and pyelonephritis without the above features, such as without complications which are mentioned, are called simple UTI. Why we need to classify? It is very simple. The treatment for simple cystitis in adolescent is just 3 days. That is a new guideline, just 3 days. Whereas the treatment for cystitis in children is 5 to 7 days. Whereas the treatment for 5 to 7 days. Whereas the treatment for complicated UTI is 7 to 14 days. Is 10 to 14 days. 10 to 14 days. Is 10 to 14 days. Then what else we need to know apart from this? What else we need to know? What is the drug of choice? For simple UTI, the oral antibiotic amoxiclav can be given. What is that? Amoxiclav can be given, or cefixime can be given. Third generation cephalosporin or cefixime can be given. Okay, the same cystitis, same amoxiclav or third generation cephalosporin such as cefixime can be given. Whereas for complicated UTI, ceftriaxone, IV ceftriaxone should be given. What drug? IV ceftriaxone should be given, right? Then you can ask, IV ceftriaxone can be given. Okay, then you need to know what is the basic investigation of choice whenever you suspect a case of urinary tract infection. So remember, the presentation is, as I told you, the presentation is upper UTI often presents with high grade fever, renal angle tenderness, etc. Lower urinary tract infection often presents with the cystitis, low grade fever, etc. But as far as pediatrics is concerned, a fever without focus. What is that? Fever without focus. Always the first diagnosis is UTI, urinary tract infection. Fever without cold, without cough, without skin infection, without liver, without spleen, without ear pain, without pharyngitis. Always you need to consider UTI as the first diagnosis. And what is the basic investigation you need to take? The basic investigations are: one is indirect test. So what are indirect test? Urine routine. What are indirect test? Urine routine. So what are all the three things that can be seen in urine routine? So the first one is in urine routine you will see pus cells. How many pus cells has to be present to diagnose urinary tract infection? Then it depends upon two things: whether it is a centrifuged sample sample, or it is a case of an uncentrifuged sample. So centrifuge, uncentrifuged. Okay, so let's go to the, so let me repeat, one is centrifuged, okay, sample, another is uncentrifuged sample, uncentrifuged sample. Okay, centrifuged sample means it is more than 5 pus cells, more than 5 WBC per cubic millimeter, whereas uncentrifuged sample means it is more than 10, okay, 10 WBC per cubic millimeter. So this is the indirect evidence, but it can also occur in, but remember, whenever you see, okay, cubic millimeter, okay, but it doesn't mean that whenever you see WBCs in your urine routine, it doesn't mean that you are dealing with a case of urinary tract infection. So what is the thing I want to say? I want to say urine pus cells doesn't always mean it is UTI. There are other causes for sterile pyuria. What does it mean? Sterile pyuria means pus cells are present but no bacteria. That is called sterile pyuria. Okay, so what are all the causes for sterile pyuria? 1. It can occur in appendicitis. 2. It can occur in TB cystitis. 3. It can occur in partially treated UTI. So these are all the conditions it can cause. These are all sterile, some causes for sterile pyuria. What other indirect test? The other indirect test are dipstick method. What? Dipstick method. So in dipstick method, two things they will see. One is leukocyte esterase. What is that? Leukocyte esterase. If leukocyte esterase is positive, it is an indirect evidence of presence of bacteria in the urinary sample. Leukocyte esterase. Okay, second one is nitrate. Nitrate in urine. So these are all sensitive, unspecific, but remember, but the bladder, that a urine has to be in the bladder for a minimum of 4 hours. These are all indirect methods. So one is leukocyte esterase in urine, second one is nitrate in urine. It can be detected through a dipstick method. So these are all the indirect method. So what is the direct method? So direct method means it is urinary culture. So direct method is urinary culture. So what are all the samples that can be taken for urinary culture? The samples that can be taken as the gold standard sample is midstream. Okay, midstream sample. First void urine in the morning. And it should be more than, I repeat, it should be more than 10,000, 1 lakh. Okay, colony forming units. Then it will be considered as positive. Okay, and it should be a single organism. Multiple organism means it is a contamination. It is a single organism. Multiple organism is always a contamination. If it is a suprapubic aspiration, the second sample is suprapubic aspiration, because less than 2 years it is unlikely to collect midstream sample. In suprapubic more than 10 power 3, the recent guideline says that more than 10 power 3 or otherwise 1000 colony forming units per ml. Okay, the third one is catheter sample. What is that? Catheter sample. You put a catheter inside the urinary bladder and take it. Catheter sample, which is more than 10 power 4. That means 10,000 colony forming units. And other thing, in an infant, okay, with pyuria. Pyuria means in centrifuge sample, uncentrifuged sample. So infants with pyuria and symptomatic, that means fever, means this colony forming units can be reduced to, cutoff can be reduced to 10,000 colony forming units. So what is the basic thing I want to say? The basic thing is the direct method is gold standard test is urinary culture. There are 4 samples. Midstream urine first white sample should be more than a lakh single organism. If it is a suprapubic aspiration sample, 1000 colony forming units. If it is catheter sample, more than 10,000 colony forming units. In any case of PUO in an infant with the pyuria, again more than 10,000 colony forming units can be taken into account. These are all what the ways of detecting. So which one should not be done? Which one should not be done? Never ever rely or never ever do. So this is very important. Never ever do 2 samples. Never ever rely on 2 samples. What are all those 2 samples? So one is what? Napkin samples or diaper samples. It is highly contaminated. One is diaper sample, it is highly contaminated. Second one is bag samples. Bags highly contaminated. Bag sample, say, which is highly contaminated. Highly contaminated. Second one is bag samples. Okay, right. So these are all the samples that you are not supposed to do, that you are not supposed to take. So a simple revision. What about E. coli, simple UTA? What are all the classifications? Second one is what are all the my handwriting will be bad, so this seems to be fine for me. Okay, centrifuged and uncentrifuged sample, indirect method and direct method. Third one. So what is the third one? Then what are all the risk factors? What are all the risk factors for UTI? Risk factors for UTI. 1. What are all the risk factors for UTI? 1. So female sex is a risk factor. Second one is less than 3 months. They are more prone for UTI because of hematogenous spread. Second one is less than 3 months is a risk factor. Third one is whenever you catheterize, catheterization is a risk factor. Catheterization is a risk factor. Vesico-ureteric reflex, is a risk factor. Any instrumentation is a risk factor. Then posterior urethral wall is a risk factor because of bladder stasis. And then any spinal occulta, spina bifida, okay, any spinal abnormalities leading to obstructive uropathy is a risk factor. So these are all the risk factors for recurrent urinary tract infection. And treatment is also mentioned to you. Okay, treatment is mentioned to you. So previously it was presumed that you need to extensively investigate any case of UTI, but right now those suggestions are gone. So when I need to investigate, so for all UTI, for all culture positive UTI, okay, remember the first and foremost thing is ultrasound kidney and bladder. Okay, ultrasound kidney should be taken for all cases. Then you can have 2 things, whether it is normal or whether it is abnormal. So if it is normal, if it is a first episode, okay, if it is a first episode UTI, and it is E. coli UTI, and if your ultrasound is normal, no further investigations are required. Okay? So if it is a first episode UTI, If it is a E. coli UTI and your ultrasound is normal, no need for further investigations. Whereas if it is a recurrent UTI, I repeat, if it is a recurrent UTI, second, if it is a recurrent UTI, even if it is E. coli, if it is a recurrent UTI, or if it is a recurrent UTI, or it is a first episode non-E. coli UTI, non-E. coli UTI. That means if your culture organism grows Proteus, Klebsiella, Pseudomonas, then high chances for urinary tract abnormality. High chances for urinary tract abnormalities. Okay. So in case of high case of urinary tract abnormalities, high chance. So in these cases, what you need to do? So again, when you need to take an ultrasound abdomen for an UTI, so either during you can take, no issues, either during treatment you can take, or after completion of treatment you can take ultrasound abdomen. There is no such contraindication. But if your, I repeat, if your ultrasound is normal, I repeat, if your USG is normal, I am sorry, if your USG is abnormal, if your ultrasound is abnormal, or I told you, a non-E. coli UTI, then you need to do next test. What is called that? MCU. What is called MCU? What is called MCU? MCU is micturating cystourethrogram. Micturating cystourethrogram. You need to take. Here a radioactive dye will be injected into urethra, will be injected into urethra, and it will coat the urinary bladder as well as the ureter. This will find out posterior urethral wall. This will find out posterior urethral wall. This will find out your vesico-ureteric reflex. This will find out your vesico-ureteric reflex. And the third one is, it will find out your neurogenic bladder. It will find out your neurogenic bladder. These things can be find out. When you need to take an MCU, very, very important. MCU should be taken only, I repeat, MCU should be taken only after 2 months of completing the treatment. 2 months of completing the treatment for UTI. Never ever try to take during UTI, because it itself can lead to sepsis. MCU should be taken 2 months after completing UTI. Okay, then the third text is, if MCU is abnormal, if MCU is abnormal, then you can take DMSA scan. What? DMSA scan. So this DMSA scan. So what is this DMSA scan? This DMSA scan will find cortical scarring that occur as a result of UTI. Okay, cortical scarring that occurs as a result of UTI. When this DMSA should be taken, okay, then when this DMSA scan should be taken, this DMSA scan should be taken only 4 months after treatment. Only 4 months after treatment. Why? Because majority of scars will disappear in course of time. Majority of scars will disappear in course of time. That's why if scar persists beyond 4 months, it indicates that there is a chance for chronic kidney damage. kidney damage, because it is presumed that it is a permanent scar. It is presumed that it is a permanent scar. Okay, permanent scar. So what are all the investigations that we need to take, my dear? I repeat, one is urine routine or urine puzzles, which include, one is puzzles, second one is leukocyte esterase, third one is you will take urine for nitrate. These are all the indirect tests. So what are all the imaging methods? One is, for all cases, ultrasound. For all cases, ultrasound KUB after UTI treatment. UTI after UTI treatment. Second one is what? For all cases for abnormal USG, you need to take DMSA scan. Oh, I am sorry. You need to take MCU. When MCU should be taken? 2 months after. 2 months after treatment. And the third one is DMSA scan. And the third one is DMSA scan. DMSA scan should be taken after 4 months of treating UTI. So this is the simple picture that I want to say. What are all the investigations? These are all the things we need to say, right? Then, so in case of, what are all the causes for risk factor, as we discussed already? So these are all the things we saw regarding urinary tract infection. Risk factors, one more risk factor I failed to mention is immunosuppression. Prolonged antibiotics. This immunosuppression and prolonged antibiotics are prone for candida. Usually candida will not cause. If candida causes, then it can be either immunosuppression or prolonged antibiotic. Okay, right. So these are all the investigations that we need to take. Then antibiotic prophylaxis, whether so these are all the treatment. So what are all the things we have discussed, my dear friend? So what is a simple UTI? What is a complicated UTI? What is an upper UTI? What is the lower UTI? What is the drug of choice for simple UTI? What is the drug of choice for complicated UTI? How long you will treat simple UTI? How long will you treat a complicated UTI? So what are all the direct tests for UTI? What are all the indirect tests for UTI? How many colony forming cells in case of how many colony forming cells for suprapubic, for catheter, for one more thing, for a catheter midstream sample. And then okay, so can I treat? One more point I want to mention. So now I have a case. Of, okay, one more question. Now a child is asymptomatic. But its colony forming count is more than, I repeat, more than 1 lakh. Will you treat? Don't treat. Never treat. Don't treat. Never treat asymptomatic bacteriuria. This is called asymptomatic bacteriuria. Never treat them. And also never treat if there is, how will you know contaminated sample? Contaminated samples are usually more than one organism. Don't treat. And majority of them, each and every colony count will be less than 1 lakh, so don't treat. Again, mixed organism, don't treat, which is often a contamination. Again, what are all the things that you want to see? That you want to examine in a case of, in any case of urinary tract infection? So what are all the histories and what are all the other histories that you will ask? Very, very, very important. Okay, so very, very important. So what are all the things? One is urinary stream. Poor urinary stream. Okay, poor urinary stream. What does it indicate? Posterior urethral wall. Poor urinary stream indicates posterior urethral wall. Ballooning. Okay, ballooning. Ballooning of prepuce while passing urine indicates phimosis. Second is ballooning indicates phimosis. Okay, indicates phimosis. Second one, you need to look at the sensation against the perineum. Okay, you need to look for abnormal sensation around the perineum. Abnormal sensation around the perineum can be an obstructive, can be a spinal cord issue, spinal cord issues. Second, you need to look for a sacral dimple, and you need to look for, one is sacral dimple, you need to look for tuft of hair over spine. What does this indicate? Sacral dimple indicates occult spina bifida. Both of them indicates occult spina bifida. And then you need to ask one more thing. Again, constant dribbling of urine can be again due to anorectal malformations, can be due to an anorectal malformations. What are all the other things you can ask for apart from this? So dribbling of urine, anorectal malformations. So next thing is, what will you ask? Palpable bladder, very important. Palpable bladder. What does palpable bladder indicates? Again, posterior urethral wall. Palpable bladder indicates posterior urethral wall. Okay, what else? Again, you need to look for the most important thing, bladder bowel dysfunction. What is that? Bladder bowel dysfunction. It is usually associated with severe constipation. The loaded colon will not allow bladder, to get emptied. Which one? So poor urinary stream, ballooning, sensation around the perineum, spinal cord issues. So these are all the things. Okay, and then what is this bladder bowel dysfunction? It is usually associated with the constipation. And how to find out? The children usually, very important, the children usually will have crossed, okay, usually will have crossed legs, usually will have crossed legs. Okay, one. Second most important point, they usually press their heel over, heel of foot over the perineum, press the heel of the over perineum. This two habits is called Vincent. This two habit is called as Vincent-Kuest. Okay, this two habit is called as Vincent-Kuest. So always ask whether the child while passing urine is crossing the legs, whether the child is sitting and sitting with squatting, sitting with the heels pressing over the perineum. So this is the indication for bladder bowel dysfunction. This indicates bladder bowel dysfunction. Always treat constipation. Always treat the bladder bowel dysfunction. Without treating bladder bowel dysfunction, n number of antibiotics will not work. Always treat constipation and bladder bowel dysfunction. So what is urinary? When will you give prophylaxis? Prophylaxis. Before that, you need to know what is called vesico-ureteric reflex. That is reflex of urine from bladder, okay, from bladder to ureter and pelvis is called as vesico-ureteric reflex, and it can lead to reflex nephropathy. Which one? Vesico-ureteric reflex. Previously it was thought that most common cause for recurrent UTI. More previously it was thought that most common cause for recurrent UTI, but now it is bladder bowel dysfunction is the most common cause. Is the most common cause for recurrent UTI. Which one? Bladder bowel dysfunction is the most common cause. So what is this UTI? There are 5 grades. So there are 5. What about this urinary tract infection? What about this vesico-ureteric reflex? There are 5 grades of vesico-ureteric reflex. What are all those vesico-ureteric reflex? And you all know that the investigation of choice to find out vesico-ureteric reflex is your MCU. So what are all the 5 grades? Let me tell you what are all the 5 grades. So let me say this is your kidney and this is your ureter. This is your kidney and this is your ureter. So this is your kidney and this is your grade 1 reflex from the bladder up to mid ureter, and ureter is non-dilated, grade 1. So what is grade 2? Again, grade 2 is ureter not dilated, but urine get a reflex up to pelvis. Gets a reflex up to pelvis. So in grade 1 and this is grade 1, this is grade 2. Grade 1 and grade 2 non-dilated ureter. So grade 1 and 2 non-dilated ureter. In grade 1 reflex up to mid ureter. In grade 2 reflex up to pelvis. Reflex, urine gets reflected into pelvis. Whereas in grade 3, grade 4 and grade 5 are associated with mild ureteric dilatation, moderate ureteric dilatation and severe ureteric dilatation. Mild, moderate and severe ureteric dilatation. Grade 3, 4, 5. Okay. Moderate, mild, moderate. Whereas, so mild ureteric dilatation, moderate ureteric dilatation, severe ureteric dilatation. Apart from that, grade 4 is associated with calcial blunting. So you will see these calyces will be blunted. That is grade 4. And what is grade 5? Loss of, these are all papillary impressions produced by the pyramid, and papillary impressions will be lost. Loss of papillary impressions. So what is grade 5? Grade 5 is loss of papillary impressions. So these are all the 5 grades of vesico-ureteric reflex as found by the micturating cystourethrogram. So I repeat what is grade 1. Grade 1 is non-dilated. Grade 1 is non-dilated ureter. Grade 1 is non-dilated ureter, reflex up to mid ureter. 1. Okay, then what is grade 2? Again non-dilated ureter, reflex into pelvis. Okay, whereas grade 3, what is grade 3? So grade 3 is mild ureteric dilation. What is grade 4? Grade 4 moderate ureteric dilatation. And then grade 5 is severe ureteric dilatation. In grade 4 it is associated with calcial blunting. Whereas in grade 5 it is associated with the loss of papillary impressions. So what is the treatment? So in grade 1 and grade 2, grade 2, okay, grade 1 no bladder bowel dysfunction, grade 2 no bladder bowel dysfunction. So no prophylaxis needed. No need to give any Prophylaxis. Again, no prophylaxis is needed. Daily drugs. Whereas if grade 1, okay, whereas if grade 1 and 2 plus bladder bowel dysfunction, that is constipation, bladder bowel dysfunction, then prophylaxis should be given. So what are all the prophylaxis you can have? Once daily at night, once daily night dose. Common is cotrimoxazole or cephalexin or cefadroxil or cotrimoxazole, cephalexin or nitrofurantoin. Once daily dosage. How long you need to give? How long? Minimum 2 years or 1 year after UTI. 1 year after UTI. If bladder bowel dysfunction is present, prophylaxis till bladder bowel dysfunction resolves. Whereas in grade 3, 4, 5, you need to give prophylaxis till 5 years. You need to give prophylaxis till 5 years or till bladder bowel dysfunction resolves. But if despite prophylaxis, if breakthrough UTI occurs, then plan surgery. What is the surgery? Ureteric reimplantation. Ureteric reimplantation. Okay. In grade 3, 4, 5, you need to give choice to parents because it is prone for renal scarring. The parents should be given choice, either prophylaxis and plan for surgery if breakthrough UTI occurs, or directly go for surgery. Okay, directly go for surgery. There is one treatment called deflux. There is one surgery called deflux, that is injection of hyaluronic acid at the ureteric orifice. Is practiced some places, but not standardized. Okay, so that's it. We have completed our discussion on urinary tract infection. Let me give you a basic thing. This will be given to you, don't worry. Less than 1 year, more common in boys. Equal ratio. More than 1 year, more common in girls. E. coli, non-E. coli UTI. E. coli UTI, no urinary tract abnormalities. Non-E. coli UTI, urinary tract abnormalities. Simple UTI means lower urinary tract infection or pyelonephritis without any complication. Complicated UTI means with complications. Okay. Treatment is for simple cystitis 3 days of amoxicillin or clavulanic acid. For cystitis in children 5 to 7 days. For complicated UTI 10 to 14 days. Ceftriaxone. Always fever without focus. Think in terms of urinary tract infection. Indirect test and direct test. Indirect test is WBC. More than 10 in WBC per cubic millimeter. In uncentrifuge, in centrifuge more than 5 WBC. Sterile pyuria can occur in appendicitis, TB and partially treated UTI. Dipstick method, leukocyte esterase and nitrate detection. Gold standard test is culture. Midstream sample more than 1 lakh. Suprapubic more than 1000. Catheter sample more than 10,000. Partially treated UTI more than 10,000. Never do 2 samples. Diaper samples and back samples. Risk factor female sex less than 3 months. Catheterization, vesicoureteric reflex. Spinal abnormalities in immunosuppression and prolonged antibiotic candida can occur. Posterior urethral wall. For culture positive UTI, always the only investigation that should be done in all cases is ultrasound kidney. So for first episode, 𝐒𝐿 UTI, only ultrasound abdomen. Ultrasound abdomen is normal, no prophylaxis. In case of recurrent UTI, abnormal ultrasound or first episode non-𝐒𝐿 UTI, you need to go for MCU. MCU should be done 2 months after UTI. MCU will find out posterior urethral wall, vesicular reflex, neurogenic bladder. MCU, as I told you, should be taken 2 months after completing treatment for UTI. And then to find out the scar, DMSA scan that should be done 4 months after treatment. If scars persist more than 4 months, there is a chance for chronic kidney damage. Chronic kidney damage. So what are all the histories? You will ask: poor urinary stream, ballooning, sensation around spinal cord, sacral dimple, tuft of hair, dribbling of urine, palpable bladder, bladder bowel dysfunction, that is Vincent cursed. The child will press the heel over the perineum as well as with crossed legs. Okay, always treat constipation, always treat bladder bowel dysfunction. Prophylaxis in case of vesico-ureteric reflex, grade 1 and 2 will resolve on its own without bladder bowel dysfunction. Without bladder bowel dysfunction, no need for any prophylaxis. With bladder bowel dysfunction, prophylaxis still it resolves at least 1 year after UTI or 2 years after or 2 years, up to 2 years. If bladder bowel dysfunction is persists, prophylaxis still bladder bowel dysfunction resolves. For grade 3, 4 and 5, prophylaxis till 5 years, usually it resolves by 6 to 10 years or till bladder bowel dysfunction resolves. But despite prophylaxis, if breakthrough UTI occurs, you need to plan for ureteric implantation. In grade 3, 4 and 5, choice should be given to the parents whether they go for prophylaxis and then surgery breakthrough UTI occurs or directly go for surgery. That deflux injection is not a standard procedure of choice. So with this, I am completing my discussion on urinary tract infection in children. Thank you. Thanks a lot. I am completing my session right now. Let me see. Okay. So that's it. This is over from my side. Akash. Thank you. Thanks a lot. So these notes will be given to you. Don't worry. Thank you.